very good morning, ladies and gentlemen. Once again, I would like to welcome all of you on behalf of the Society for Health Research and Innovations for another Shri Knowledge Academy CPG program. Today, we are honored and thrilled to have a well-experienced and very competent speaker for our session, Dr. Krishant Dalpadatu, a cherished graduate from the University of Colombo and went on to get his DCH and also MD in Pediatrics from Postgraduate Institute of Medicine. He obtained his foreign training degree in United Kingdom and went on to serve more than 8 years in numerous Sri Lankan provinces in numerous teaching hospitals. Currently, he's a consultant pediatric neurologist at Teaching Hospital, Kurunegala. So now I would like to give you some the routine housekeeping tips. As we all know that the webinar link will be available from 9 a.m. to 9:45 a.m. to join in. No light attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NC CPD guideline. This is to improve and maintain the standard of the CPD programs conducted by Shri. Once again, I would like to thank all of you for joining to this CPD program and hope you will get much needed knowledge from our distinguished guest. Consultant Pediatric Neurologist, Dr. Krishant Dalpadatu, sir, please, I would like to invite you to join with us and deliver your wisdom to all of the people who's joining with us from all over the country. Thank you very much.
And good morning to everybody who has joined the webinar series conducted by Shri. I'm going to talk to you today about headaches in children and maybe a little bit beyond what you have currently know as knowledge into something that you can use for your practice as well. Okay, so why talking about headaches? Why have I put this skull with a lot of holes as my first picture? Now, this is a skull that had been found in Egypt, and the skull dates back to 1500 BC. And you can see a man performing a surgery here. And this is called trephining. So, in ancient literature, the papyrus leaves, and also in India, they describe this trephining as a mode of treatment for headache. So a gruesome way to treat headaches in the ancient times. So other ways of treating migraines and headaches during those days had been bloodletting, cutting veins and letting blood out, leeches, again to suck out blood. So those days headaches had been treated like that. Now we don't treat headaches like this, so you don't see these gruesome type of procedures used for treating headaches. But however, having said that, now there has been an interesting study by a few doctors who have too much time on their hand. They have looked at the main characters of Hollywood films, and they have found 23 films where the main character had headache, and they had looked at the ending, and the main character who had the headache had come to a very violent and spectacular death at the end of the Hollywood film. So even now, people with headaches are not looked at in a very kind way or very nice way, even in the popular culture. Now, so having aroused your maybe interest about headaches, what I going to talk to you about in the next 1 hour. So I will be talking to you about why we need to learn about, or why we need to discuss pediatric headaches. Why is it this important to talk about pediatric headaches? We will talk about the various types of headaches. We will also try to discuss how to differentiate the various types of headaches through the what is called headache history and a headache specific examination. And then obviously the most common of all the headaches in children is the tension type and the migraine headaches. So we will discuss a little bit about the type, pathophysiology and treatment, which is what I think most of you are interested about, because that is what will be helpful in your practice or your treatment of headaches. Now, why do we need to talk about pediatric headaches? One thing, it is one of the commonest health problems in children. So studies have shown that it is one of the top 5 health problems in children. So if you take a population of children, it is very likely that some of them will come to you with various types of headaches. So when they present you with headache, you have to know how to differentiate a sinister headache from maybe a benign headache. So there are reports of prevalence about 40% of headaches by 7 years, which increases up to about 75% by 15 years. And in another study in Canada, they have found 26 to 31% of children in the teenage years reporting headaches at least once per week. So once a week, about 30% of children who are at the adolescent age group come and complain that they have headaches. And this headache prevalence has now shown to have increased. So when the headache prevalence about 60 years, 50, 60 years ago had been about 14%, to 20 years later to about 52%. And now it must be even more. So these are studies not from Sri Lanka, because we don't have this kind of prevalence studies, but the data coming from all over the world is quite, from the south and the north hemispheres are all the same. Headache is a very significant problem in children, and it is increasing in prevalence. So that it is very likely that you will at least get one child per month coming to you if you are doing a practice complaining of headaches. Just talking about why is it important, we know that when a child comes to you with headache, it's a challenge. Now unlike adults, children are unable to express, articulate what is happening to them. So the symptomology analysis of the symptoms might be a little difficult, and it might not fit perfectly to a certain pattern as well. And little children, examination is even more difficult due to their temperament. And signs are also not very easily elicitable. So having a good understanding of this problem helps us to maybe help the parents as well in in finding out what is wrong with the child when they complain of headache. Now, that is headache. So what about migraines? Migraine is obviously the commonest headache syndrome that the children come up with. So again, the prevalences are from 1 to 3% in 7-year-olds to 4 to 11% in about 15-year-olds. And so basically, it's 5 to 7% of the children from 12 to 17 years will complain of headache. And here in red, you can see the headache prevalences gradually increase. The migraine prevalence also gradually increase with the advancing ages from a child to a teenager. And when you look at the males and females, obviously, due to the hormonal issues in females, the headaches are a little higher in females. The migraines have a higher prevalence in female. Another issue that we have to look at is headaches are not just standalone problems. Headaches are a constellation of issues that are coming up with other disorders as well. So if you take a child with headache, a big number will have epilepsy, that 18 to 15%. That is like 1 in 10 to 1 in fifth of children will have epilepsy as well. A 1 in 4 children will have a tic disorder. And a big percentage also have psychiatric issues, mood disorders as well. And diabetes and atopy have been also been described as probable problems these children with headaches have as comorbidities. So you can see that a child with a headache, when it presents to you, is a very important issue that you need to resolve. So one thing is it is very common. You are likely to encounter a child with headache very often in your practice if you do a practice. The second thing is, due to the nature of the child's headaches, it might be a challenge in coming to a diagnosis. And finally, there are other associated issues in these children who have headaches as well. So when a child, now headaches, there is a association or International Headache Society, which is the apex body that is involved in classification, defining guidelines and treatment in headaches. In children, they have the primary headaches. You can see that types of primary headaches the children get: migraine, tension type headaches, things like that. Now, the main, so for migraine, there are main 6 types and 13 subtypes. And altogether, primary headaches, there are about 72 types of primary headaches that are there. The secondary headaches are the ones that are caused by some other illness causing you a headache. So for instance, a tumor causing a headache, or a vascular cause causing a headache. So if you look at the classification, so this is the latest classification of the International Headache Society, is the third installment of the ICHD. There is a grand total of 141 secondary headaches. So 72 primary headaches and 141 secondary headaches. So when a child comes to you with headache, you can see what a lot of things you might have to consider as differentials if you just, take the headache as it is. So, and the biggest problem the parent has when a child complains of, recurrent headaches intermittently, the biggest worry the parent has, even though they do not tell this to you, is the question that lingers in their mind is, does my child have a brain tumor? Now, even though I said there are, 141 secondary type of headaches and 41 type of primary headaches, the parents' worry is this sinister? Does this child have a brain tumor? I think that is what they want you to exclude when they show their child to you, even though they might not tell you this. So how do you, I always tell this, how do you differentiate apples from oranges? So we'll say apples are the primary headaches, the oranges are the secondary headaches. So how do you differentiate the apples from oranges? So that's That's quite easy if you take a proper history. So what this is called the headache history. Headache history is the mainstay or the main tool that you have in identifying or in distinguishing this problem of secondary and primary headaches. So why do I say that the headache history is the main tool that you have? Now, there are lots and lots of studies which have looked at what is the best tool to look at differentiate them into a primary and secondary headache. Can you do it by investigations? Can you do it by physical examination? Can you do this by focused history? So what they have found is that now they have looked at 500 pediatric neurology patients who come with headache, and out of that, 1/3, 150 of these children with headaches, the history had provided the correct diagnosis and management in 100% of these patients. So 150 children, 100% of the time they have had success in diagnosing and deciding on the correct management. So that shows you how important a good history is, even though it might be challenging to get to ask the right questions, to get the correct information from the parent regarding their child's headache. So what do you ask? What are the questions that you can ask to get over this problem? So there are 18 questions that you can ask here. These are not my questions. These are from a study which I had shown earlier, which had given the 100% correct diagnosis, which will tell you what you are dealing with. So what you can ask is, when did the headache begin? So the onset of the headache. So when did the headache begin? How did the headache begin? So were there any triggers to the headache? What is the temporal pattern like, or how had it evolved over time? What is the frequency? Is it daily? Does it happen weekly? Does it happen intermittently? Is it infrequent, or is it once or twice a year? So you're asking about the frequency of the headache. So how long does the headache typically last? So that is the duration of the headache is very important. Is it lasting a few seconds, few minutes, several hours, several days? That because we talked about international headache classification, the duration of that headache will tell you whether it's a tension type headache, whether it's a migrainous headache, things like that. Does the headache happen at any particular time or circumstance? So certain headaches, like headaches due to raised intracranial pressure, might wake you up early in the morning with headache and vomiting. So does the headache come at a certain time due to circumstances? So those are important things. Is there an aura or a prodrome? Does the child look drowsy? Does the child look less interested, cannot concentrate? Is the mood off for a few days before the headache begins? And then where is the pain? Is it over the temporal areas? Is it frontal? Is it in the occipital area? Those are quite important aspects that you need to ask. So what is the pain like? Certain headaches like the migraine type headache is throbbing or pulsatile. Certain headaches are like burning type sensation. So it's important that you ask what the pain is like. Are there any associated symptoms? What are the associated symptoms you're talking about? Nausea, vomiting, photophobia, and phonophobia. These are important differentials in differentiating headache, a migrainous headache. So what do you do during headaches? Certain children would like to go to a quiet room, to a dark room, put a pillow over their head and sleep. Is that what the child does? Does the child reduce his physical activities or stop playing during headaches? Those are important. What makes the headache better? So does the pain medication make the headache better? Uh, does nausea or does vomiting make the headache better? Are there symptoms in between headaches? So what happens in between? So you get headache, there's certain period where the child might be free of headache and you get another headache. During that interval period, what happens to the headache? Are there any other health problems? We talked about diabetes, we talked about asthma, which may be comorbidities of headache. So those you have to ask about those as well. Are you taking medication for headaches? Is there a family history of headaches? And what do you think is causing the headache? So these are important questions that has been devised to get a proper get proper information for you to identify the correct diagnosis for the type of headache the child is having. The next is the examination. So, for the few patients, examination might also be quite helpful. Temperature and blood pressure are important. Temperature is because there might be intercurrent illness, a viral illness that is causing the headache, which you might have missed. Blood pressure, we know, is important in teenagers to adults who high blood pressure causes headache. Growth parameters, a chronic illness might be in the background and is causing delayed growth, which might have been missed. OFC, hydrocephalus or macrocephaly, can indicate raised intracranial pressure. Skin examination, we know that if the child has neurocutaneous manifestations, which are common in conditions like neurofibromatosis, there are you get certain manifestations in the brain as well, such as tumors. So these children are prone to get headaches. Vision and fundoscopy is very important. A child who has a refractory error commonly comes and complains to you that there are headaches, usually with reading or during school time. And fundoscopy is obviously to look at the papilledema. Now, having done that general examination, it is important that you go on to complete the physical examination by doing a full neurological examination. Finding a focal neurological sign is the one thing that will tell you this is not a primary headache and you are dealing with a likely secondary cause. And what they have found is if the child is having a brain tumor, the headaches caused by the brain tumor, 85% of these children will have some sort of neurological finding by 8 weeks. So within 2 months of a tumor, some form of a neurological manifestation will be there. And virtually all the cases, every child who has a brain tumor will have at least one positive neurological sign by 24 weeks, that is by 6 months. So by 6 months, from 2 months to 6 months, you are bound to get neurological signs. So if you miss those neurological signs, you are likely to prolong the diagnosis, and a tumor that which can be surgically excised might become intractable if you miss this. So what are the 3 neurological signs that have the most predictive value? So what you have to remember is paralysis, a focal weakness, and anything to do with reduced awareness of consciousness, reduced loss of confusion or loss of consciousness. So those 3 are the 3 main neurological findings which has the strongest predictive value when it comes to diagnosing a underlying probable tumor, which is the cause for this child's headache. So something that I have found in that you need to examine is ataxia. Ataxia, we usually try to elicit by uh, doing the tandem gait or asking the child to walk and seeing whether the child uh, has a tendency to fall. Uh, now, when you do this ataxia, if it's very slight or mild, you might miss it. What you can do to make this more prominent would be to ask the child to stand from one leg and try to spin once or twice. Then the child will fall if the child is ataxic. This is something that I found useful when I was doing my foreign training. Right. So now that is the general and neurological examination. There is what is also called a headache specific examination, which you can do to specifically find out other issues. Now you look for bruise to look for vascular malformations causing headaches, such as arteriovenous malformations. Now the problem here is in children, sometimes you might hear bruise over the skull, but most of these bruises are benign. But if you hear a prominent diastolic component, then that bruise is significant. So infection, you are looking at neck stiffness, Koenig sign. Problem is in certain children with migraine, you do get neck stiffness due to the activation of what is called the trigeminocervical complex. But other findings such as CRP, temperature, the temperature, the investigation findings might tell you that this child is having a probable infection. So raised ICP, raised intracranial pressure, something that you always need to look for to identify a probable tumor. Papilledema we talked about, then nausea, vomiting, problems in vision, those things you need to, and the blood pressure, you have to look at to identify raised ICP. Trauma is always a problem. Sometimes the funny thing is sometimes parents bring the children saying, my child is having a headache. When he was one or now imagine the child is about 10 years or 12 years, and the parents complain is when he was 2 or 3, he fell from the swing, or he had a fall from the bed or whatever, and he hit his head. Is that fall is now causing headaches in my child? So that is a very common question the parents ask. But trauma per se, long time back, will not cause headaches. Obviously, that is common sense. But if the child had significant trauma recently, and a concussion recently, that might cause headache. So musculoskeletal pain, again, any issues with the cervical spine because of the close proximity to the pathophysiology of migraine, we will discuss about that, can cause any stiff joints in the cervical spine, any problem there can cause headaches. Temporal mandibular joint examination is very important. You know that any inflammation of the temporal mandibular joint also can cause headache. So examining the temporal mandibular joint is important. Now, investigations. The main problem when a child comes with headache is if you are not sure about the diagnosis, if you are if you think now this is you are not completely sure whether it's a primary or a secondary headache. if you encounter a very anxious parent, you have this, the tendency is to write investigations very quickly, to refer a child to do a CT scan or MRI scan. And this commonly happens. You don't have focal neurological signs, you don't have any sinister red flags, and the patient is referred to get a CT scan or MRI scan done. If your headache history, if you have done a thorough headache history, as I have said, if you have done a full physical examination, if there are no focal investigations, there is no need for you to do, and all these are normal points towards a probable primary headache, there is no need to do neuroimaging. That is, I think, an important uh, take home point here, that you confidently make your diagnosis and decide and tell the parents and reassure the parents that investigations are not necessary, specifically the neuroradiological investigations. Another common investigation I get requested is EEG, the electroencephalogram. Now, EEG used to be common practice some time back when a child gets headache, but the yield of a EEG when a child has headache is very low, and in my opinion, it's bad practice to do EEGs when child presents to you with headache, because the migraine per se can cause changes in the EEG, and you might be in a dilemma. There was previously something called epilepsy headache, which has been taken off from the International Headache Classification. So you do not get a headache before a seizure or during a seizure. You are likely to get a headache only after the seizure and post seizure cephalalgia. So there is no need to do a EEG as a routine investigation for headaches. Okay, so what we discussed in the first part of the lecture is childhood headaches. Why is it important? What are the main methods that we have, which is the history and the examination in differentiating the headaches to what it is. And we also said, if you have a completely normal examination with no focal neurological signs, you are unlikely to get any further by doing neurological investigations such as CT, MRI, or EEG. So when a child comes to you with headache and your neurological examination is normal, there are a few things that can cause this headache. So one is obviously your refractory errors. You are going to refer this child for a visual examination. The second one is your sinusitis. You can elicit sinusitis by examining the child. It is usually there only when the sinuses are developed, which is usually over a child who is 6 years old. And the third one is your migraine and the tension type headaches. So from one of the questions that you have from the questions that you have sent, most of the questions have revolved around trying to what you have asked me from those questions, or how to identify a migraine headache, how to differentiate tension type headache from migraine, so things like that. So I see that most of you know that in children migraine headaches are common, and you want to differentiate and you want to know how to treat migraine and tension type headaches. So I will concentrate the rest of my lecture on migraine and tension type headaches. So the first thing, now I personally think that tension type headaches and migraine are a continuum of a same spectrum. So a tension type headache might be the milder version of a migrainous headache. Why I say that is because when you look at the headache classification, uh, the criteria to diagnose are quite similar. So for a tension type headache, you have to have more than 10 episodes of the following that you can see on the screen. 10 episodes. Now the duration of the tension type headache should be 30 minutes to 7 days. Now this duration in a migraine is slightly prolonged, and you have to have 2 or more of the following characteristics: bilateral, pressing or tightening type, mild to moderate intensity, not aggravated by routine physical activity, no nausea, vomiting, phonophobia, and no other headache in the ICHD classification fits this type of headache. So basically, this is a milder version of a migraine. The duration is less, and you do not have nausea, vomiting, photophobia, and phonophobia. So if I maybe go a little further to my migraine classification, so you can, this is the migraine with aura classification. You have 5 attacks lasting 4 to 72 hours. In children, the duration is less. We take it as 2 hours to 3 days. So in children, again, these are basically adults. It's bilateral. Pulsatile or throbbing is what children usually complain. And it is moderate to severe. And it's aggravated by routine physical activity. And in migraine, you have nausea, vomiting, photophobia, and phonophobia. So going back. So basically 30 minutes, no nausea, vomiting, photophobia, and not aggravated by routine physical activity. So the most of the patients that come to you, and most of the patients that I see who have been diagnosed have migraine, have are tension type headaches due to the duration, because they don't have nausea, vomiting, phonophobia, and physical activity is not aggravating them, but they have been diagnosed as, and they're mild to moderate. This is the type that is most commonly encountered rather than migraine in my personal practice. Another interesting thing about tension type headache is these, I'm sure you have encountered this. Children complain that they have tenderness over their head. So what is called cephalalgia. So there's pericranial tenderness, and that is also type that is put as a type of tension type headache. That is commonly seen in these children. And as I said, tension type headaches are very common, 30 to 78%. It is much more commoner than migraine. And I see that most of the tension type headaches are misdiagnosed as migraine and treated as migraine as well. Right. So coming to migraine. So when you look at migraine, you have to look at migraine as attack and a disorder. So why do I say that? I'm sure you have, a neurologist, I see many patients with epilepsy. So it's similar to epilepsy. So you have the seizure and the epilepsy. So seizure is the attack. Epilepsy is when you get recurrent attacks of seizures. So likewise, in migraine, you have the attack and you have the disorder. So what is the disorder? We'll talk about the attack in detail. But the disorder is when you get the repeated attacks. Now you call it an episodic migraine when you have less than 15 days of attacks per month. And you call it a chronic migraine, obviously, when you have more than 15 attacks per month. So 15 or less is episodic, 15 or more days of the month are affected, that's called chronic. These are important little things because the treatment might differ. You might decide to change the treatment if it's chronic or episodic. And because it's a disorder, because disorder is a constellation of signs and symptoms, you have family history, you have triggers like missing sleep, skipping meals, alcohol, and certain weather conditions. Some patients complain of cold weather causing migraine, hormonal issues, stress. On these things are important because when it comes to deciding and discussing treatment with these children, these are very important things. Now, so when then the attack per se, the migraine attack has 4 stages: the prodrome, the aura, the headache, and the postdrome. So exactly like a seizure, these are conventional, demarcations, but they might be overlapping to some extent. If you take a seizure, you have the pre-ictal or the prodromal phase, the ictal phase, and the post-ictal phase. So likewise, a migraine will also have a prodrome. Then you get the aura, headache, and the postdrome. So what is a prodrome? Prodrome is when the child is showing some form of unwellness for a few days. So this might be up to about 3 days. The child might be showing certain signs. These are mood changes, inability to concentrate. I know some children complain that their handwriting becomes poor maybe a day or two prior to the attack. So these are what you call the prodrome. Aura, you get the visual aura. I'm sure you know about the auras. There's visual auras. You sometimes get weakness, which is called the hemiplegia. What is the motor aura? You can get auras that come from brainstem, such as nausea, various hallucinations you can get as auras. Then you get the headache, and then the postdrome is once the headache settles and you are still unwell for some time. So this migraine is this all dancing, all colorful, very emotional sort of severe attack. And what happens is the child goes into a very dark room, puts a pillow over the head, vomits several times, and is unwell for a few days until the headache attack goes off and the child comes back. So something like that. So is the attack. So we discussed about this. There was one question which asked, how can we differentiate a childhood migraine from adult migraine? So basically, here the duration is less. It's 2 to 72 hours. In children, you don't get this classic unilateral location. It's usually bilateral. They are unable to localize. They have this poor linguistic ability, so they are unable to properly describe the quality of it. Moderate to severe is what you get, but how do you find that out is by asking about their behavior. Do they stop playing? That is a very important thing that tells you that this is quite moderate and quite severe. And we talked about aggravation by routine physical activity, which they completely stop. As I said, goes back to dark room and lies in bed for some time. It's important that you ask about nausea, vomiting, photophobia, and phonophobia, which are important identifiers of a migraine without an aura. And then you have the migraine with the auras, which we talked about. The auras are the visual, sensory, speech, motor, brainstem, and retinal auras. You can just Google ICHT3, and these slides I have taken straight out of the ICHC, the website. So you can have a go through of the whole classification. Now, what is the pathophysiology? So once you put away the secondary causes, and you tell the parent this child is having migraine. They will ask you why how is my child is how is my child having migraine, and why is my child having migraine? And in teenagers, they ask, when will I get another attack? So these questions need to be answered. So what is the pathophysiology? So basically, you have a genetic or inherited tendency, that you get a child, the parent also has immigrant, several of the parents, siblings, the child sibling have migraine, and this inherited tendency leads to a loss of control of the sensory inputs, which I will describe. And what are the sensory inputs that they lose? The trigeminal and the neurovascular pathway mediated responses lead to activation of what is called inflammatory soup in the dura mater, with a lot of various substances, which you don't need to know much in detail, except that that is what is happening. And at certain times in life, when there are hormonal activations during environmental factors, genetic factors, the loss of circadian rhythm in certain cases, and the central processing pathway gets disrupted, and the migraine becomes prominent. So just what are the structures that are involved? The hypothalamus, brain, and the limbic system. This is just the accepted mechanism of how you get a migraine these days. I remember when I was a medical student, there was a problem-based learning about migraine, and what we discussed then was this vasodilatation of the cerebral vessels causing migraine, pain receptors in the various blood vessels and all that. I still remember discussing that as the pathophysiology. Now that type of explanation is now completely off the window. So now, so basically, the pathophysiology is what I have described. So important. There are a few important structures in the brain, as described in the previous slide. In the brain stem, you have these suprasalivary nucleus, which gets multiple afferent parasympathetic signals with regards to triggering of a migrainous attack. Through that, there is activation of the parasympathetic pathway to the dura mater. It goes to what is called a sphenoparietal ganglion. And in the dura mater, around the blood vessels, there is a lot of inflammatory mediators. You can see names such as CGRP, PCAP38. So you don't need to remember these. So what is, you have an inflammatory soup, as I described, which is stirred to extent that there's a lot of irritation and swelling and inflammation. And these signals are relayed back through the trigeminal nucleus to the what is called a trigeminal cervical complex. Now, the trigeminal cervical complex is supplied by the C2 or the cervical nerve, cervical 2 nerve, and this is how it is mediated. And I'm just describing this because there are important pathophysiological manifestations here, as well as some of the modulators of treatment is through this whole pathway. So if you remember, I told that neck stiffness can be confusing as a meningeal irritation in infections as well as migraine. It is due to this problem. Now, this trigeminal cervical complex, or the C2, when it's activated, causes neck stiffness. And in migraine, you get neck stiffness. And about 50% of the children older in adolescent years complain of neck stiffness when they get a migrainous attack. Or they complain that their neck is, there's pain in their neck. This is causing headache. But actually what is happening is the migraine is causing the neck pain. So treatment. Now treatment, I'm talking about the pharmacological treatment first, but treatment is basically a package in migraine. You just don't dish out medicine. uh, it is a whole what's called a multidisciplinary approach or a package of things when it comes to treating a child. You do not treat all the children with migraine with drugs. So we'll talk about that. But when you decide that you need to treat these children, there are basically two components to choosing medication. The first component is the acute attack. Obviously distressing. Child is having vomiting, so you need to relieve the symptoms. So what can you do to relieve the symptoms? So that is called acute symptomatic treatment. What has the most evidence for treatment of now asthma, sorry, migraine treatment? There has evolved over the years. The first drug to be identified for acute symptomatic treatment was aspirin. Then you had the ergotamines, but those things are not currently used. What has the most evidence now is ibuprofen, acetaminophen is paracetamol, and the triptans. Out of these, what is recommended is that you use an appropriate drug early in the attack of a migraine attack. So you don't wait until the child has full-blown symptoms and give the drug, because then the drug might not work. And you need to use a adequate dose. So using a subtherapeutic dose will not uh, relieve symptoms. So if you are using brufen or ibuprofen, you need to use a 10 milligram per kg dose. Acetaminophen, here the dose should be around 20 milligrams per kg. Sorry for the typing mistake there. So 15 milligrams is what we use for fever. That is not adequate. You need to give something like 20 milligrams per kg dose. Now the triptans, I don't think we have nasal sumitriptan, but there are oral triptans available. What I frequently found useful is if you combine the ibuprofen with a triptan, that seems to relieve an acute attack quite quickly, rather than using one of these alone. Now the second category of drugs that you need for use for treatment is the prophylactic treatment. There are a conglomerate of drugs, number of drugs that are available here. uh, you have the ACE inhibitors, you have the propranolols, the flunarizine, then the pizotifen, amitriptyline, the anticonvulsants. So lots of prophylactic agents. So what drug to be used? What is the most efficacious? So this is a study that looked at all these drugs. Basically, all of them are as effective as one another. So there is no one drug which is superior. And my personal practice is to look at this as in an individual basis. So say if you want to use propranolol, uh, I would check whether the child has asthma, issues like that. Then I will not use propranolol. If the child is awaiting the scholarship exam or the O-level exam, I will not use something like topiramate or anticonvulsant drug like valproate. They have known problems with reducing the intellectual capacity or uh, the the ability to solve mathematic problems. Certain drugs cause sedation, certain drugs cause weight gain. I will individualize this list, and according to the child's circumstance, I will use the prophylactic aid. Now, these might not be something that you are very familiar with. There are certain non-invasive neuromodulation treatments that can be found elsewhere in the world. So the first one is the transcutaneous transcranial magnetic stimulation. Then you get the transcutaneous, second picture is the transcutaneous vagal nerve stimulator, the transcutaneous supraorbital stimulator, and finally you get the direct current stimulator. Now these, some of like the transcranial supraorbital stimulator is available over the internet. You can order it and can get it down. So these, what they do is they use what is a technique called neuromodulation, or try to take away the neural input and try to modify the sensory input. And these are useful when the drug treatment is not giving you enough effects. When there is chronic headache, when you have cluster headaches, these type of uh, uh, machines or equipment might be useful. And then you have the invasive neuromodulation. Out of most of these are now out of context, not used, like deep brain stimulation, or what I described about the sphenoparietal ganglion, its involvement in the pathophysiology. But certainly, the great occipital nerve, which is arising from C2 and going up. So if the child has tenderness in the cervical region, uh, blocking that nerve uh, has been shown to be as effective as using medication. And Botox is used for chronic migraine. The problem is over the scalp, there are 41 points that you need to inject Botox. And Botox, as you know, is very expensive, and you have to use it in adolescents and older children and adults. Basically, you do not consider drugs or these invasive treatment in all the children. It is a package, as I said. So you need to have lifestyle modification that are going concurrently with the treatment. Or lifestyle modification alone can sometimes help uh, treating migraine. So one of these things is the headache diary. I'm sure every child with migraine should have a diary, and writing that itself has been shown by certain researchers. Looking at writing the headache diary itself, it can be a very therapeutic measure in reducing the headache. Deprived sleep causes headache, migraine. Dehydration causes migraine. So these has to be addressed. Uh, so caffeine needs to be reduced. But nowadays, elimination diets are not recommended as treatment. Regular physical activity, relaxation techniques, cognitive behavioral therapy, looking at stress, emotional factors, what is causing mood disturbances, and getting psychiatric help if nothing is working can also be helpful. So it is not just you treating, you are getting other people's help, also looking at environmental factors, lifestyle factors, modifying all this in trying to reduce the headache in children if it's becoming troublesome. So thank you so much. That comes to the end of my lecture. Uh, I hope I did not overburden you with a lot of information. So if I just summarize what I said, headache is a very, very common problem in children. You are likely to encounter a child with headache. Even if you are doing adult practice, this is very common. So how do you approach this is, firstly, you need to have a diagnosis. You basically need to think, am I dealing with something sinister or am I dealing with something benign? So if you take a proper history, do the examination, you are most likely in most cases to come to a diagnosis that this is not a sinister event. And out of the benign ones, there are two common conditions that we talked about, the tension type headache and the migraine headache. So the tension, you think about tension type headache as a milder version of a migraine with less in the time duration, physical activity, and some of the associated symptoms not being there, like photophobia and phonophobia. Migraine, we discussed about migraine, the attack and the disorder. So treating the attack is the acute symptomatic treatment. Treating the disorder, you use the prophylaxis, and the lifestyle modification. And if you don't get any response, there are other ways such as neuromodulation that can be effective, that can be used to tackle that problem. So thank you so much. I'm going to hand back the screen to Sahan to take over from here.
Yes, sir. Thank you very much for that well focused and well oriented lecture on this childhood headaches. I think from your wisdom, sir, that many of my fellow colleagues received clear explanation for many of and variety of questions or variety of problems that they had on this topic. So once again, our sincere thanks goes to Dr. Prashant Dalbadatu, the consultant pediatric neurologist from the Teaching Hospital Kurunagala, for his excellent lecture and his precious time that he has shared with us with the Sri Academy. So there are a few questions popped up in the Zoom chat, and many questions also were there before the lecture was conducted. So all the questions that came before, we will be answering through email as soon as possible. Moreover, there are a few questions on the chat box. I would like to read one by one. So this question is regarding the tension type headache. Is there a specific time duration for these 10 episodes should occur?
I'm not quite sure what you meant by a specific time duration. Are you asking whether it can occur at night or daytime or something like that? I don't think that there is a specific time as per se, but the duration is 30 minutes. It should be more than 30 minutes. If I go back to the, can I put the slide again?
Yes, sir, you can put. And the question also asks about the duration only,
There
sir.
is no specific
Specific
time
time
of
duration.
day as such,
Uh-huh.
but the duration is around 30 minutes. So let me go back to the slide. So it should last from 30 minutes to 7 days. There is no specific time duration, but more than 30 minutes. Yes.
Okay, sir. Thank you very much. There's another question. Why there are two columns in the type of headache charts, differentiating males and females? It seems that he has found charts with different.
Can that question be a little more clarified?
Yes, sir. We will get that doctor the question clarified furthermore, and if it is necessary,
There are
we
two
will
columns.
email the answers.
Now that chart was taken from another lecture. So it is not the chart. What I wanted to show was that that is the prevalence of headaches in males and females. So what is basically projected in that chart is the prevalence of headaches in females is much more than in males.
Okay, sir. Another question comes in from Dr. Aruni. She asks that how long should the prophylactic treatment to be given?
So prophylactic treatment, we usually say we don't give it as a short-term for cough and cold. We don't use it like 7 days or 5 days like that. It is longer than that. And it is again coupled with your lifestyle modifications. And how you look at it is, as I said, it's a package. You have to not just give the prophylactic medication, you have to incorporate the lifestyle modifications as well. And then you ask the patient to maintain what is called a headache diary. And if the symptoms have completely resolved, you can try, after looking at the headache diary, you can try to tail off the anti-migraine drugs rather than completely stopping it suddenly. That way the child might not get a sudden attack. So duration will depend on how the symptoms evolve with your treatment, but it is not quite short term. You might have to give for a few months.
Thank you, sir. And another question from Dr. Shahan. Can we use any triptan or only sumatriptan?
Yes. Now I'm not very versed with the use of triptans. There's only one triptan that is available in the market at the moment in Kurunagala, and that is also being prescribed the license to be used for more than 12 years. But looking at the literature that is coming out from outside, what they describe is using the nasal spray, sumitriptan nasal spray. Now, what the evidence show is that the nasal spray is much more effective than you taking a tablet. So taking a tablet in the form of a triptan is less effective than the nasal spray. And also the other thing that is, if you read the literature that you can see is you can use sumitriptan, and then if it's not effective, don't abandon it completely. You can change. There are lots of triptans. I think about more than 10, around 10 triptans that are there. So you can change over to another triptan and see. So that is the approach. But in children, the use of triptans is much less. We tend to use Brufen or paracetamol, but when it's older, I definitely, in an older child, I definitely use a triptan and Brufen together.
Okay, so expanding the same question, sir, that Dr. Shahan wants to know whether solmitriptan nasal spray that is available, whether it can be used.
Yes, so uh, definitely the nasal spray is much better than the oral tablets. So if the nasal spray is available, you need to use it, and you need to check how whether it's licensed to be used in children.
Thank you, sir.
At the
And Dr.
moment, all these triptans are licensed to be used for children more than 12 years old.
Thank you very much, sir. Another question from Dr. Itarshan. Please explain the criteria of episodic TTH. Is it no photophobia or no phonophobia?
Yes, so when you take the tension type headaches, the tension type headaches are mild to moderate, does not aggravate with physical activity, and does not have photophobia and phonophobia.
Okay, sir. Another question, sir. This is uh, this is something I have noticed that
Of
doctor
the
has
two,
noticed.
I mean, you can't have either. You can't have photophobia and not phonophobia. Both cannot be there. If that was the question that was asked.
Okay, sir. Thank you. And another question asks about the duration to continue the prophylactic treatment.
Yes, so the duration will depend on the patient's how the symptoms evolve. It is very difficult to say, give 3 months and stop medication. There are certainly children who have been on prophylactic medication for much longer than that. So you might have to individualize depending on the response that the child gets for this treatment. One thing to say is that all children will not respond the same way. There are patients that come to me sometimes who have been on drugs for a long time. Sometimes they have used 4 or 5 of these drugs, 2 or 3 concomitantly. So, I mean, just draw a line and say this is the duration is very difficult, and it's medicine. You play as you go with the flow. See how the child responds, but it is not just treatment. That is the important thing, is you are not concentrating just on treatment. I always tell the parents, this is the treatment is temporary. You have to use the whole package to get response. And if you if you just use treatment, ignore the environmental or the the triggers and the lifestyle modification, if the conditions are right, once the treatment is stopped, the child gets the attacks again. That is the experience that I have.
Thank you, sir. Another doctor, Dr. Karuna Ratna, wants to know that she has experienced that some children with non-specific chronic headaches who do not have sinus tenderness clinically improve with the course of antihistamines. Can this be due to the sinusitis? So it could be something else.
So this is again now a pathway of uh, treating migraine. Now, Pizofen works through the antihistamine pathway. And then you have things like cyproheptidine, which we use, what is called peritol, which has a side effect which reduces migraine. So I think you are probably treating, even though you are using antihistamines, you are probably treating either tension type headache or a migrainous type headache.
Very clear, sir. Thank you very much. The last question, because the time is running out. It's a very important question. When to refer a patient with headaches?
So
Probably to.
a very good question.
Yes, sir.
The most important of the questions that I think are so far. Now, the purpose of doing this lecture is for me to, stop treating these children with headaches, and for the primary care doctors to take over and treat this. So my role becomes minimal, and I don't, have to see these children. I think most of the children that come to me with headaches do not need to be seen by a consultant pediatric neurologist. They can be managed by a primary care doctor. So if you do a proper job, do the proper examination, I mean, you don't need to send the child to a pediatrician or a pediatric neurologist to do a imaging. You can do the imaging by yourself, and if you identify the tumor, refer to that person. And you can try the primary medication first, at least one of these primary medications, and lifestyle modification, and see whether it works. So if it doesn't work, then obviously send to me, but then the number of patients that I see becomes much less and less.
Okay, sir. Thank you very much. Once again, our sincere thanks goes to Dr. Krishant Dalbadatu, a consultant pediatric neurologist. And so, of course, you went beyond and basics of this topic. So thank you very much for all of you for joining with us today also. You have the link on the chat box to get the e-certificate. Please kindly give us your feedback also and fill it. There are some post-assessment questions also. You can answer those questions also to show us your knowledge and to gain more knowledge about the topic that we've discussed today. And you will obviously receive the e-certificate for participation after you fill out the feedback forms and the feedback forms and also the post-assessment questions. And we sincerely hope that you would join with us the following Sunday as well with another different, very informative and very timely topic in the field of medicine. Thank you very much for all of you to joining with us. And also, once again, thank you very much to Dr. Krishant Dalbadatu to sharing your wisdom and helping us to clear many issues that we had on this topic. Thank you very much and have a very pleasant day. Thank you.